Welcome back, everyone. Now we'll talk about abdominal examination. I understand there will not be clinical examination questions, but in order to answer the renal system, you'll also have to understand the abdominal examination system. When I talk about the abdominal examination system, the inspection is the key. There are no questions based on the inspection. When you start your examination by the general examination in abdominal system, you'll also have to ask the patient to outstretch his hand with the wrist extended. Why are you doing this? Because you'll find tremors in the patient. And how are tremors related to the kidney disease? It is with the renal transplant, the patient will be on cyclosporin, tacrolimus, then the patient will have tremors. So, renal disease patients or renal transplant patients with tremors, please think of medication up toxicity, that is tacrolimus toxicity. I also want you to understand whenever you are checking for tremors, please examine the fingertips. Why are you checking the fingertip examination? It is because the diabetic finger pricks are present. Patient with renal transplant and diabetic finger pricks, there are two causes of diabetic finger pricks. First thing is diabetic nephropathy leading to renal transplant, and medications which can cause hyperglycemia, that is, cyclosporin can cause hyperglycemia. Next, examination of the hands in renal system. What are we talking about? We are talking about AV fistulas. Patient with AV fistulas will have relevance to renal transplant because patients who are waiting for renal transplant will have functioning AV fistula. And how do you know that the AV fistula is functioning? You'll have to auscultate the AV fistula and you will find a continuous murmur. Next, we talk about the AV fistula, which is not working. That is called matured AV fistula. If the AV fistula is not working, or if the AV fistula has not got any murmur, it indicates that the patient might have received renal transplant. Next, we talk about pulse. In patient with AV fistulas, what is the most important pulse? It is the hyperdynamic pulse because there can be high output cardiac failure. Inspection of JVP in renal transplant or renal problems. Whenever there is renal problem, there will be fluid accumulation and JVP will be elevated. Remember that. And why are we checking the oral cavity? Whenever the patient has got hyperplasia, gingival hyperplasia, think that the patient can be on cyclosporin and the patient might be having a cyclosporin toxicity in patients with the renal transplant. That is what I want you to remember for oral cavity because gingival hyperplasia is usually the cause for cyclosporin toxicity. Coming to the abdominal examination proper, on inspection, if you find that there is a scar in the right loin region or right iliac fossa, please think of a renal transplant scar. Whenever you find a renal transplant scar, you'll have to understand that the patient has got a renal transplant. When the patient has got a puncture needle mark on the scar, think that the patient might be having a renal biopsy. Very important. However, this cannot be asked in USMLE step 2, but these are all the points that you will have to think of renal transplant in USMLE step 2 examination. When I talk about the palpation, palatability is not felt. Where is it? Or the abdomen is full. Why am I talking about abdomen? Fullness of abdomen. Polycystic kidney disease is one of the most important thing you'll have to understand. Patients with polycystic kidney disease will have big kidneys. And what are the other disorders that can have big kidneys? Polycystic kidney disease, amyloidosis, and diabetes. These are the three most important things that I will remember for USMLE step 2 and step 1 when the patient has got big kidneys or large kidneys. What are the conditions where patient will have small kidneys? It is the nephrosclerosis, hypertensive retinopathy, and renal artery stenosis. I will remember that the patient will have small kidneys. Next, I want to talk about legs. Whenever there is pedal edema, think that the renal function is compromised or the patient can have a compromise in the liver function, we call it as decompensated liver disease. I also want you to auscultate the abdomen. Why are we auscultating the abdomen? It is not only for the abdominal examination to hear the bowel sounds, but also for the renal bruit. Renal bruit is heard in renal artery stenosis. In the examination, you will find a classic question saying that a young age female patient presented with acute onset of shortness of breath. When the patient presented with acute onset of shortness of breath, what happened? The patient was diagnosed to have pulmonary edema. In the books, we call this as a flash pulmonary edema. In the questions, you will have to understand that the flash pulmonary edema presents with acute sudden shortness of breath in young patients who has got a history of renal artery stenosis. That is when you diagnose the patient to be having a acute flash pulmonary edema on a background of renal artery stenosis. This is the most important clinical examination or the clinical scenario you will find in examination USMLE Step 2. Next, I want to talk about the renin angiotensin aldosterone system. Remember, hypotension or decreased blood volume or decreased blood pressure is the most important stimulating factor for the renin release. Whenever the renin is released, it is the angiotensinogen from the liver that is converted to angiotensin 1 by the renin. Whenever angiotensin 1 is formed, it is acted upon by the ACE enzyme from the lungs and is converted to angiotensin 2. Remember, angiotensin 2 is the potent vasoconstrictor in the body. Whenever there is a potent vasoconstrictor in the human body, it leads to widespread vasoconstriction and it causes increased blood volume. But angiotensin 2 not only causes the widespread vasoconstriction, but it also stimulates the adrenal cortex. Whenever the adrenal cortex is stimulated, the aldosterone is released. Whenever the aldosterone is released, it causes increase in the sodium and increase in the sodium resorption. Remember, in life and in universe, whenever there is sodium, there is water. That is why we feel hungry when we eat salt substances. So aldosterone not only increases the sodium, it also increases the water and it causes reabsorption of both sodium and water from the renal tubules, thereby increasing the blood pressure and the blood volume. This is how renin angiotensin aldosterone system works. Next, we talk about differential diagnosis of peripheral edema. Already we know that there are two differential diagnoses we discussed. One is the liver failure and next one is renal failure. I also want you to understand that heart failure and sometimes the venous obstruction can also cause peripheral edema in the question. What about the nephrotic syndrome, which causes hypoalbuminemia? It also causes peripheral edema. Whenever there is trauma, whenever there is sepsis, it can also cause peripheral edema. I will tell you what are all the causes and underlying pathophysiological mechanisms that can cause peripheral edema, and we will also discuss about the clinical scenarios that can cause peripheral edema. For step one, people who are going for step one, remember increase in the hydrostatic capillary pressure causes the movement of water from high pressure to low pressure. So patients will have movement of water from the high hydrostatic pressure to low hydrostatic pressure. What are the conditions which can increase capillary hydrostatic pressure? First, most important thing is heart failure. Whenever there is heart failure, there will be accumulation of the blood in the veins, that is the capacitance vessels, and it causes increase in the hydrostatic pressure. Whenever there is increase in the hydrostatic pressure of the veins, the water moves from the veins to the interstitial spaces and it causes peripheral edema. That is why heart failure causes increased capillary hydrostatic pressure and it can cause peripheral edema. Remember, heart failure causes bilateral peripheral edema. Talking about another condition which can cause increase in the capillary hydrostatic pressure, but it can only be caused because of the venous obstruction that is involving unilateral limb, that is the venous obstruction. Whenever the venous obstruction happens in one limb, it causes increase in the hydrostatic pressure of that limb and causes unilateral peripheral edema. Remember, heart failure, liver failure, and kidney failure causes bilateral peripheral edema. I also want you to understand that in patient with nephrotic syndrome, there will be hypoalbuminemia, which can cause bilateral peripheral edema. This is because of the loss of protein. Proteins have the tendency to maintain the oncotic pressure. Whenever there is loss of protein, there will be decreased oncotic pressure. And whenever there is decreased oncotic pressure, the water moves from the decreased oncotic pressure to high oncotic pressure. Water moves from low protein area to high protein area. In nephrotic syndrome, the protein in the intravascular substance or intravascular lumen is so low that it is decreased to a level that the interstitial protein is present. So the water moves from decreased capillary oncotic pressure to high oncotic pressure, thereby causes peripheral edema. The two most important causes which can cause decreased capillary oncotic pressure is nephrotic syndrome and patients with malnutrition. Patient with malnutrition, they will have protein losing enteropathy and can cause peripheral edema. We discussed in gastroenterology that cirrhotic patients will also have hypoammonemia because of the decreased intake of the protein. So, protein restriction must not be done in patients with cirrhosis and patients with malnutrition. Why? Whenever there is decreased albumin, it causes decreased oncotic pressure and it results in peripheral edema. That is why cirrhotic patients develop peripheral edema. Next, we talk about other causes where peripheral edema is present, but it is because of the increased capillary permeability. Whenever there is increased capillary permeability, remember that the capillaries are injured. What is the reason the capillaries are injured? It is because of the sepsis, infection, inflammation, burns, and severe inflammatory disorders that there will be increase in the capillary permeability. For USMLE, I want you to remember that the burns, trauma, and sepsis are the three most important causes that can cause peripheral edema. Remember, in sepsis, it can also trigger inflammatory reaction and can cause acute respiratory distress syndrome. This is what we learned in pulmonology. I also want you to understand whenever there is severe allergic reactions, there can be inciting injury to the capillaries and it can cause capillary permeability that is altered, that is increased. So severe allergic reactions can also cause peripheral edema. Whenever there is obstruction of the lymphatics, say for example, ascites or lymph node dissection, the capillaries or the lymph node capillaries or the lymphatic obstruction happens and the lymphatic pressure increases. Whenever the lymphatic pressure increases, there will be interstitial oncotic pressure that is increased. So this causes the peripheral edema as well. As far as USMLE is considered, I want you to remember that patient with breast cancer who has undergone lymph node dissection will develop unilateral upper limb edema. That is because of the lymphatic obstruction. Gradually, this lymphatic obstruction changes to lymphangitis. And this angiitis, as a part of recurrent inflammation and severe inflammation, it changes to lymphangiosarcoma. That is what you'll have to diagnose in the question, saying that a elderly patient who or a middle-aged female patient who has recently undergone breast surgery or diagnosed to have breast cancer, please think of lymphatic obstruction as one of the cause. Next, we talk about differential diagnosis of abdominal pain. As far as I know, for USMLE Step 2, I want you to remember whenever there is the right upper quadrant pain that is referred to Right trapezius pain, it is the cholecystitis that I want you to remember. And in cholecystitis, the most important question they ask is fat female 50 lady patient developing right upper quadrant pain after having food is cholecystitis. We also discussed in cardiology that most of the patients with epigastric pain with the bradycardia, please think of angina, please think of cardiovascular problems. So epigastric pain that is present, not radiating or radiating down the abdomen, think of angina as one of the most important cause. I also want you to understand that epigastric pain radiating towards the back is a diagnosis of pancreatitis until otherwise proved. Right iliac fossa, what did we discuss in gastroenterology? It is the appendicitis that we need to consider. Whereas in pregnant patient, the right upper quadrant pain is a diagnosis of appendicitis. Whereas left iliac fossa pain with fever, nausea, that is a sister of appendicitis, it is the diverticulitis that we will need to consider. Patient with loin pain, it is a renal calculi until otherwise proven. Patient with dysuria and loin pain, it is pyelonephritis until otherwise proven. Patient with loin pain with suprapubic pain, it is the urinary tract infection and cystitis that we will have to diagnose until otherwise proven. This is the differential diagnosis of abdominal pain. However, there are two other most important diagnoses in the questions they will be asking you. Young female exercising sudden development of pain. Ovarian torsion is one of the classic example. Athletes, boys, sexual activity, recurrent pain previously, think of testicular torsion as one of the most important differential diagnosis of abdominal pain that can be presenting as a suprapubic pain or a loin pain or as a differential diagnosis for ureteric colic or colic. Next, I want to talk about cystitis and pyelonephritis. We talked about cystitis and pyelonephritis. Whenever I say cystitis and pyelonephritis, in the question, they will tell you or talk about hematuria. I want you to understand there are two types of hematuria that is present. One is glomerular hematuria and non-glomerular hematuria. And when do you diagnose hematuria? In the questions, they will tell you clearly that on urine analysis, it is more than 3 RBCs per high power field. That is when you will have to diagnose hematuria. What did we learn in the initial part of our lecture? We learned that urine analysis, if it is more than 2 RBC on urine analysis, it is considered to be an abnormal hematuria. Remember, in hematuria for USMLE, in the questions, they will mention that this patient has got 5 RBCs on urine analysis. Then you will have to differentiate between glomerular hematuria and non-glomerular hematuria. We already learnt that the non-glomerular hematuria patient complains of gross hematuria. That is, the patient will or can see that there is the discoloration of urine. Whenever there is non-glomerular hematuria, I want you to understand that it is because of the nephrolithiasis or renal calculi, or there can be problems with the prostate, or there can be renal cell carcinoma as well. However, painless hematuria or gross hematuria in elderly is a diagnosis of urinary tract cancer. Especially patient with history of smoking will be having transitional cell carcinoma. Patient who is got a suprapubic pain and has got hematuria, think of cystitis as one of the most important differential diagnosis for non-glomerular hematuria. I also want you to understand that the patient with the loin pain, patient with dysuria, having non-glomerular hematuria, pyelonephritis is also one of the important causes for non-glomerular hematuria. Remember, patient with diabetes, patient with analgesics, patient with sickle cell, patient with trauma can have papillary necrosis and can present with non-glomerular hematuria. These are all the clues that you will have to look in your question to diagnose a non-glomerular hematuria cause. Remember, whenever there is non-glomerular hematuria, patient will usually present with the signs and symptoms of either infection or obstruction, that is the calculi or renal stone. In patient with elderly, it is the malignancy that is to be considered until otherwise proven. Remember, in patient with non-glomerular hematuria compared to glomerular hematuria on urine analysis, you will find proteinuria in glomerular hematuria. So, urine analysis can detect protein in cases where glomerulus is affected. Very basic, and you must not go to the exam if you do not know this. Whereas in non-glomerular hematuria, it is most often the blood that is diagnosed or identified in urine analysis. Remember, whenever there is glomerulus that is involved, the RBC can easily cross the glomerulus. Whenever the RBC crosses the glomerulus, the shape of the RBC is distorted. So, on urine analysis, if there is normal structure of RBC that is maintained, it is the non-glomerular hematuria that you will have to think of. Whenever the RBC structures are damaged, it is the glomerular hematuria that you will need to think of. Talking about glomerular hematuria, I want you to understand glomerular hematuria is a microscopic hematuria. And the common things for glomerular hematuria is all the intrinsic renal disease or the all the glomerulonephritis. Say, for example, post-streptococcal glomerulonephritis, IgA nephropathy, which causes hematuria as the most predominant symptom. Think of glomerular hematuria. We already learnt that IgA nephropathy usually presents with gross hematuria with 2-day history of infection, whereas post-streptococcal glomerulonephritis usually presents with history of 2 weeks infection with hypertension and proteinuria, which is minimal, but hematuria that is maximal. Remember, whenever in the question, the examiner mentions that the patient has got signs of nephritic syndrome that points towards glomerular hematuria. And how do you determine that the patient has got hematuria? It is on the urine analysis that is more than 3 RBCs per high power field in the question you will find. And in the question, classically, you will find that the patient has got RBC of more than 5 per high power field. That is when you will have to diagnose hematuria. I talked a lot about hematuria because cystitis and pyelonephritis can be having blood but no protein, and the blood that is appearing on the urine analysis is basically a normal appearing RBCs that gives you the diagnosis of urine analysis and the presence of blood. Next, talking about the treatment of cystitis and pyelonephritis, I want you to understand in the question, you will have to differentiate if it is a complicated cystitis or uncomplicated cystitis. Remember, if it is a young patient and has got no history of disorders, it is an uncomplicated cystitis. But in the question, whenever you are thinking about urinary tract infections, I want you to understand and I want you to remember in the question, you will have to rule out diabetes, you'll have to rule out pregnancy, you'll have to rule out urinary tract obstruction, or you will have to rule out iatrogenic causes, that is catheter in place, or patient has got a history of urinary tract infection where cystoscopy has been performed. Patient has got a renal transplant, patient has got a liver transplant, patient is on immunosuppression, patient has got a urinary tract infection in the hospital. Think of complicated cystitis that needs to be addressed. Remember, whenever a male patient is having a urinary tract infection, the next best investigation of choice is you will have to diagnose or you will have to think why the male patient has got a urinary tract infection. It is very uncommon to have a young male patient presenting with urinary tract infection. It is very uncommon that the patient will have a young onset urinary tract infection in males. It is only up to the sexually transmitted disorders that you will need to think of if the patient has got a dysuria. If the patient has got a dysuria in the question, we already discussed this. In the question, if it is a less than 35-year-old male patient presenting with symptoms of urinary tract infection, you will have to diagnose or rule out sexually transmitted infections. It is only after the age of 35 when the patient develops urinary tract infection, you will have to think of prostate or you will have to think of urinary tract abnormalities. Very important. Without this differential diagnosis, you must not go to the exam. Talking about the treatment of uncomplicated cystitis, you will have to use nitrofurantoin for 5 days. Sigma rule for medicine, wherever you practice medicine in the world. Nitrofurantoin for 5 days works furiously, but you'll have to avoid nitrofurantoin if the patient has got renal problems. The borderline or the baseline creatinine clearance that we consider in order to use nitrofurantoin is creatinine clearance of less than 60. Remember, after using nitrofurantoin, you will have to consider trimethoprim sulfamethoxazole for 3 days. That is the next most important option. If you do not have any of these two options, and if the patient is willing to go home, if the patient is not willing to use any medications, if the patient has got a history of compliance to the medications, not using the medications regularly, phosphomycin is the antibiotic of choice where we can use phosphomycin for single dose. Remember that. Next, we talk about the treatment of complicated cystitis, where the patient must be considered to be a hospital admission, catheter in place, immunosuppression, diabetes, renal failure, urinary tract infection, indwelling catheter, cystoscopies, urinary procedures, multiple medications, multiple comorbidities, elderly, whatever you say, without young age, that is considered to be a complicated cystitis. When I'm talking about complicated cystitis with all these multiple problems, fluoroquinolones for 5 to 14 days must be used. Remember, ampicillin and gentamicin is the medication of choice that we will have to select for USMLE step 2. And if the patient wants to go home, it is the outpatient patient treatment that we consider fluoroquinolones. It is usually the ciprofloxacin that is given as an answer. But if the examiner wants to twist your arm, it is the levofloxacin instead of ciprofloxacin you will have to consider. Next, pyelonephritis, and the patient has got multiple problems. Patient must be admitted as an inpatient. Consider intravenous antibiotics that needs to be changed. And when do you change intravenous to oral antibiotics? It is when the patient is improving, when the patient has got resolving symptoms, when the patient has got resolving signs, when the inflammatory markers are improving on the blood, and when the patient shows signs of improvement on clinical examination, you will have to consider oral antibiotics. Remember, oral antibiotics must be used whenever you want to make sure that the oral integrity and the gut integrity is present. Whenever you want to understand what is the cause of the urinary tract infection in males, it is the structural disorders that needs to be ruled out. Whenever the patient is being started on a therapy, please do send urine culture to find out what is the bacteria that is causing, what is the organism that is causing. In the USMLE Step 2 final exam question, you will find a classic example saying that this patient has got a repeated urinary tract infection and is now got a renal calculi. Proteus is the most important organism that you will have to pick it up. Proteus mirabilis can cause urinary tract infection in males. Saprophyticus is an organism which can cause urinary tract infection in females. I want you to remember these two organisms, and without knowing this, you must not go to the examination, please. Next, we talk about acute kidney injuries and disequilibrium syndrome. I'll send you a new link and then we'll meet there. Thanks very much.